morning and welcome to our 14th of our Town Hall series today. It's great to see everybody. As always, this is put on and sponsored by our Society for Leading Medicine, and I want to thank again our chairs, Jeremy and Caroline Finkelstein, as well as Catherine and George Masterson. They've done a great job, and thank you to everybody who's already a member for all of your support. And if you'd like more information, as always, we'll have an email address at the end if you'd like to join the Society. You know, we have a lot of great news today. We obviously had an expansion of the vaccine when it comes to Pfizer yesterday, now for 12 to 15-year-olds, so we'll be talking about that. But we're also at a time where interest in the vaccines has been waning pretty strongly, much too soon also. And so we're going to talk about those issues today as well, many of the creative things we've been doing. For example, this Sunday, which was Mother's Day, of course, at the Astros game, we did a promotion with the Astros where individuals could get vaccinated either scheduled or on the fly while they were there, and then receive an Astros ticket for 3 weeks later so they could come back and get their second dose. And happy to say we vaccinated 100 plus people doing that as well. May, of course, is the month of Mother's Day, and this past Sunday was Mother's Day. Happy Mother's Day to all of you. Mom, happy Mother's Day again. And we had a great family celebration this weekend. It's also in May, Women's Health Month, and in fact, this is Women's Health Week. And so today we're going to be focusing on some women's heart health and other health issues. As usual, today we have Dr. Dirk Sostman here with me, who will be speaking about some of the science around the vaccines and around COVID. We have Dr. Ashley Drews, who's in the background answering questions. So remember, text or chat your questions in, and she will get all of those to you as well. In a little while, we're going to hear from Dr. Trisha Roy, who's a very recent member of our institution, just joined us in October, and she's the newest member of the Gerald B. Katz Academy of Translational Research. She's going to talk to us about advanced imaging techniques. But first, we're going to start with Dr. Karla Kurrelmeyer, who is the director of our outpatient women's heart clinic, and she is currently also secretary of the medical staff at Houston Methodist, which really shows the respect and esteem with which she's held by all of her colleagues. So, Dr. Kurrelmeyer, why don't you talk to us about COVID and women's health throughout the past year?
Thank you, Dr. Boone, for that gracious introduction. So yes, we're going to focus in the next few minutes on COVID-19 and how it affects women's heart health. So COVID-19, we're going to talk first about how we know it causes heart injury. And we know it causes heart injury through blood tests, or we call these heart blood biomarkers. And they're specifically troponin I and BNP. And when they're elevated, they signify that the heart has been injured. And multiple studies so far have suggested that the injury most often is not due directly to the virus, but to the body's own inflammatory and blood clotting responses to the virus. So you can see there's a little cartoon depiction down there of the heart. Let's see if I can show it to you. And it blows up on the left, and that's showing you the right coronary artery, and you can see there's a plaque in there and a bunch of red blood cells and a COVID virus in there. And basically what happens is the body responds to that COVID virus, and that's shown in the right-hand panel. You can see that you produce antibodies, they're the little Y-shaped things. You can see white blood cells in there, which are the purple-shaped things. And you can see a plaque in there, which is that big yellow thing in there, plus the red blood cells, which are trying to carry oxygen and nutrients to that heart muscle. Basically what happens is some of those antibodies in some people are antiphospholipid antibodies, so they promote clotting. And they promote clotting not only in the legs and in the lungs, but they also promote clotting in those heart vessels. When they promote clotting in those heart vessels, a heart attack results, and those biomarkers go up, signifying that the heart has been injured because it's not getting enough oxygen and blood flow to it. There's those little purple cells in there, those are representing superactivated white blood cells. We know those superactivated white blood cells, they like elude inflammatory mediators, which are proteins, which again act on that plaque, that yellow plaque in there, and they make that plaque very, very unstable. So what happens then is that plaque ruptures, and then your own clotting factors glom onto that plaque and also completely obstruct that blood vessel, also causing a heart attack. So those are two different ways that when people who are acutely infected with the COVID virus can have a heart attack as a presenting symptom of that COVID infection. We also know that COVID-19 infection, when people are sick and they have a virus, the heart rates are much faster, the blood pressure is much lower, and basically that means the heart is working harder, so it needs even more oxygen. But if you're like the patient on the right, there's a depiction of a big plaque in there filling up most of that blood vessel. It's hard to get blood flow through there. And also, if the patient has COVID-19 pneumonia, they have low oxygen in their blood to start with. So in people with underlying coronary artery disease, what happens is they cannot expand that blood vessel. They can't get more blood flow and more oxygen to the heart muscle, even though it's working harder and demanding more. It just can't do that because it's plugged up with a plaque. And what happens then too is those blood biomarkers go up, and we see that they're elevated, and we see that there is another form of heart injury, and this is called a type 2 heart attack because it's a smaller heart attack, and it's just due to more and more, the heart is demanding more and more blood supply, and they can't get it because of those blockages. We also know in very rare cases that the COVID-19 virus can directly attack the heart muscle. We call this viral myocarditis. And I say that it's fortunate that this is rare and happens in less than 1% of patients. And why is this fortunate? Because this viral myocarditis can cause not only chest pain, but also heart failure and abnormal heart rhythms such as atrial fibrillation, ventricular tachycardia, and cardiac arrest and sudden death. So again, we are fortunate that this does not happen very often, but we do know that a cardiac MRI is the best way to diagnose viral myocarditis after all other COVID-19 related heart effects have been excluded. And we know that if an MRI supports the diagnosis of viral myocarditis, that the American Heart Association and the American College of Cardiology myocarditis guidelines for athletes advocate that they have to take a 6-month holiday from the sport just to allow their heart to heal. So they are not at risk for those arrhythmias, the atrial fibrillation, the ventricular tachycardia, and the sudden cardiac death or cardiac arrest. There is another form of heart injury that can come from the COVID-19 infection, and that's just due to the overwhelming stress from the infection and the stress hormones and the sympathetic nervous system effect on the heart. And we call that a stress cardiomyopathy or Takotsubo's cardiomyopathy. That just means that the heart muscle just gets weak and it fails in response to all this stress. The good news about this one is if you can fight the viral infection and convalesce, basically this will completely resolve and the heart function will go back to normal. Regardless of what the exact mechanism of these elevated heart biomarkers are, because they're elevated in all of these previous conditions that I talked about, the higher the level of these biomarkers when a person presents with a COVID-19 infection, we know the greater the risk of death from the COVID-19 infection. So they're really, really strong prognostic markers about how well you will do if you actually have the COVID-19 infection or presenting to the hospital. We know that echocardiography is the first-line imaging modality used to determine how COVID-19 is affecting the heart during an acute infection. And you can see there that in the upper right-hand panel, the technician is performing an echocardiogram. And the bottom-hand panel, that is an actual echocardiogram. The blood is represented by the white, and you can see a little black round mass at the very tip of the heart. That's actually a blood clot in a patient with COVID infection. So we know that there also is something called long COVID. And long COVID means that you have these lingering symptoms that persist beyond the acute infection. So you no longer test positive for the virus, but you still have these symptoms of fatigue, brain fog, shortness of breath, chest pain, and dysautonomia, which is sometimes called POTS, which stands for postural orthostatic tachycardia syndrome. And what dysautonomia or POTS is, it means that frequently when you go from a sitting to a rising position, the blood pressure drops. Or changing any sort of position, lying to sitting, the blood pressure drops, and it drops to such low levels that you feel lightheaded and like you're going to pass out. Or other times what happens is the heart just starts racing. The blood pressure is fine, but the heart just takes off like you're exercising. So the heart rates are above 100 beats per minute, and this is just due to dysregulation of the nervous system on the heart. We know that 60 to 80% of discharged patients reported at least one of these symptoms 50 days following their COVID-19 diagnosis, and 35% of non-hospitalized patients reported these long COVID-19 symptoms 14 to 21 days after being diagnosed with COVID. Now, in those patients who have fatigue, shortness of breath, chest pain, they should be screened for something called inflammatory myocarditis. And they should be screened with those heart blood markers, the troponin I and the BNP, with inflammatory markers, with an electrocardiogram and an echocardiogram. And if these tests suggest that they have inflammatory myocarditis, which is residual inflammation that the virus caused just from the body trying to fight it and convalesce, that the patient should go on to get a cardiac MRI, because the cardiac MRI will definitively diagnose if that myocarditis is present, and therefore determine that anti-inflammatory treatment with things like steroids are necessary in order to cure the heart and relieve these symptoms. The dysautonomia, or the POTS-like syndrome, which we talked about, which is the abnormal blood pressure and heart rate. So that treatment is supportive. So it requires home blood pressure and pulse logs. It requires a lot of fluid, so you push the fluids, you push the salt, and if we still can't get the blood pressure up to those levels needed so you no longer feel lightheaded or dizzy, we can prescribe medications like midodrine to increase the blood pressure, or if it's the heart rate that's racing, we can prescribe medications like beta blockers and ivabradine. The good news is these all are, they will come to an end, even these long symptoms. It just takes time, sometimes several months, but they will eventually resolve on their own. We do know that the pandemic has been hard on patients with heart disease. We know that the stress from the COVID-19 pandemic has led to high blood pressure, poor sleep habits, overeating, unhealthy food choices, weight gain, increased use of tobacco and other drugs, and this has led to new onset diabetes or uncontrol of the diabetes if it already existed, and higher cholesterol levels or uncontrol of cholesterol. All of these are risk factors for new onset heart disease or progression of heart disease that already exists. We also know that fear and anxiety has led to a lot of missed appointments to manage these risk factors, and this has led to increase in the number of heart events that we're seeing, specifically heart attacks and chest pain syndromes after the pandemic. Telehealth has really helped physicians, both primary care physicians and cardiologists, meet this pent-up demand to try and provide these preventative services to try and prevent these cardiac events. So that's pretty much all I have. Thank you very much.
Well, thank you, Dr. Kurrelmeyer. I think, one of the things that I've often said is you really don't want to get COVID, whatever age you are. I think this is exactly why, even when people recover well, oftentimes they're seeing, unfortunately, long COVID types of symptoms in your clinic. In a day, how many people are you seeing post-COVID now in your practice? I
would say in a clinic of maybe a dozen people, probably about 2 or 3 of them will have these long COVID symptoms, and most commonly it's this dysautonomia, this racing heart, this low blood pressure that frequently brings them into clinic. Chest pain less likely, but I would say dysautonomia is the number one reason.
Not fun symptoms at all for people to have. You want to avoid these. So thank you for your expertise and for your care of all these individuals. We very much appreciate it. Well, Dr. Roy, we'd like to turn to you now. You're going to talk to us about advanced imaging, and thank you for being here today.
No problem. I'm a vascular surgeon. I just started here in October, and I wanted to talk a little bit about leg ischemia, or peripheral artery disease. This is a really common, chronic, and morbid condition that we're seeing is becoming so much more severe during this COVID-19 pandemic. And some of that is because people are afraid to present to hospital, and by the time they present, it's late, and their legs are no longer salvageable. But some of it is actually the pathophysiology of the syndrome itself. And my research program here is really about developing advanced imaging techniques so that we can decide what is the best treatment for each individual patient, and really tailoring that to have the best outcomes. So, limb ischemia, what we're talking about here is reduction in the blood flow because of plaques, and so you don't get enough blood flow to the leg. This can lead to tissue loss, ulcers, gangrene, and in severe forms, you can lose your legs and even die. In critical limb ischemia patients, our amputation rates are 20 to 25%, and our mortality rates are 20% in just 1 year. So time is absolutely critical for these patients, and it's really important that we are able to reestablish definitive blood flow in a short period of time. We're seeing that since the COVID-19 pandemic has really hit us, that the number of major amputations have been much higher than usual. and our death rates are also higher. And like I said, this is multifactorial. One of the issues is patients are avoiding coming to hospital when they really need to, and by the time they do present, their legs are no longer salvageable. But another issue is the actual disease itself. So we often think of COVID-19 as being a respiratory failure issue, but as Dr. Kurrelmeyer had mentioned, there is also an issue with hypercoagulable states or high clotting states, and that's what we're seeing in the vascular surgery world. So the mechanism of it is not entirely clear, but there is a syndrome, Virchow's triad, which talks about the critical elements that are required for clots to occur. So one of the things is stagnant or stasis of the blood flow. The other is damage to the blood vessel wall. And the third one is a hypercoagulable or increased clotting state. And COVID-19 is thought to increase each of these. So stasis, because when you're in hospital or ill, you're not moving around much. Endothelial injury, so that's when Dr. Kurrelmeyer also mentioned you have this inflammatory state, and that can be damaging to the blood vessels itself. And then the hypercoagulable state, here we're seeing that the clotting factors in our blood are also getting increased. So these are some possible mechanisms of how this is actually increasing our likelihood to clot off our blood vessels and increase our leg ischemia. So currently there are two major ways that we can reestablish blood flow if you do have insufficient blood flow because of these clots or blockages in your blood vessels. One is an endovascular treatment. So this is where we make a needle poke in the groin, and under X-ray guidance, we open up the blockage from inside the blood vessel under X-ray guidance, and then we do this with balloons and stents. The other is a much larger operation, a bypass surgery. And here we have long incisions, and we're actually rerouting your blood around the blockage with usually the patient's own vein. Right now, we have no way of knowing which patients are better suited for which type of treatment. And one of the things that are really limiting us is our current imaging. So right now, X-ray angiography, which is where we inject dye and take X-rays, that is still considered our gold standard. What you're seeing in the cartoon there is a blockage of the superficial femoral artery. And on the left, with the X-ray angiogram, the red dotted line is showing you where you should see dye outlining the superficial femoral artery, but because it's blocked, you don't see dye there. But that's all you can say from this. You can just say that there's a blockage there. You don't see the blockage itself. It's invisible on this X-ray. So we don't know what it's made out of, we don't know how severe it is, and we don't know how to best treat it. Ultrasound similarly gives us not enough information. We just see that there's blockages, and even CT scans, it doesn't have sufficient soft tissue contrast for us to differentiate different types of blockages. And peripheral artery disease in the era of COVID and otherwise, it's not a single entity, it's very multifactorial. And we also have commercially available devices, many different kinds. So we can do lithotripsy or drug-eluting balloons or stenting or mechanically grind through the plaque. And each of these act in a different way and are actually effective for different types of plaque. But because we can't tell them apart, we have no rational way to choose the best treatment for our individual patients. So right now we have a one treatment fits all approach. Vascular surgeons, we all typically opt for endovascular treatment first for everybody. And then if we fail, we go on to do bypass surgery. But we have a 20% immediate technical failure rate with this approach. And even if we are immediately successful, a third of the time we have to do more interventions. This 20% failure rate, these high failure rates, are a waste of time and resources. And in a patient population where I said, we really need to have definitive blood flow as soon as possible. So having a tailored approach is critical here. So what you're seeing here is a CT angiogram, okay? You see a cross-section of the knee, and the red circle is around the popliteal artery, one of your major blood vessels in the leg. So with CT scans, we inject contrast dye and we take pictures while the contrast passes through. You see that there's an outline of a bright circle, and that's telling us that there's calcium, and then you don't see any bright signal in the blood vessel itself. So we know that it's blocked, but again, we don't know what it's blocked with. Now, with our high-resolution MRI, we see two different sequences, and with these two sequences, depending on how bright or dark a component is, we have unique imaging signatures for soft tissue, for fat, for dense collagen, and this tells us, based on the fact that it's dark on the right image, really bright on the middle image, now we know that this is thrombus. And this really changes our treatment strategy, because if this is going to be filled with hard, dense, rock-hard collagen, then I know that if I try to do a stenting procedure here, it's going to be a high risk of failure because I'm not going to be able to get through it. Now that I see that it's soft thrombus, this is something that I know that I can easily get through, but I also know that I have to be careful about embolizing that friable thrombus during the procedure. Each of these things will dictate the best treatment strategy. And not only are we able to tell what components there are, we're also able to use that MRI signal behavior to tell us how hard or soft it is, the mechanical properties of these plaque components. And so this is the approach we're wanting to build here. So, you know, we do an MRI for our patients and really have a good understanding what their individual disease is made out of, whether they're better suited for bypass, endovascular treatment, or whether they're not suitable for any intervention and require an amputation. And I think that with that kind of approach, we can reduce our failure rates, but more importantly, we can choose the best treatment for individual patients to reduce our amputation rates and increase our limb salvage in this growing population.
Well, fantastic. Well, thank you very much, Dr. Roy. So you are a new scholar in Gerald B. Katz's translational research. Tell me about that experience.
It's been really incredible. So I just started in October, and the Translational Imaging Center here has incredible facilities. I have 7 Tesla MRIs, 9.4 Tesla ex vivo MRIs, micro CTs. We have so much in terms of facilities, and this award also gives us the resources to use those facilities. So we've been able to get patients in, and have already imaged 15 patients and are developing real clinical protocols that we can implement. And that amount of progress in such a short period of time is reflective of the resources that are available here and reflective of that award.
That's great. Well, we're very grateful to the Katz Foundation for making that happen and for helping bring great people like you to Houston Methodist. And you see her eyes light up when she talks about all the technological toys she gets to use. Speaking of people who like technological toys, Dr. Dirk Sostman, of course, a radiologist, has been using those all his career. And he's here again to talk to us today about the vaccines.
Thanks, Mark. And I just have to editorialize for a minute. You know, I'm at that elderly, curmudgeonly stage of my career.
People, I think you might have been there for a while.
People, careful. I'm going to be on air, and you're going to be gone.
That's true.
That's but you know, people like me always, you know, complain about the younger generation, and you know, they're you know, whatever. But I have to say, you know, listening to Dr. Kurrelmeyer and Dr. Roy, I have to say I think the future of our profession is in really good hands. So,
Amen.
Anyway, on that note, some COVID vaccine updates. I am not going to show you the clinical trial data one more time. You've seen that before. We're actually now in the phase of getting floods of real-world evidence on the effects of vaccination. And as different countries start to get, a critically high component of their population vaccinated, we're seeing some very, very dramatic changes. Country of Israel, for example, 96% protection from infection. April 23rd was the first day since September that they had 0 deaths from COVID in the country of Israel. The public health system in Scotland showed that hospitalization was reduced by 85 to 94%, 30% reduction in household contact infections after a single dose of a 2-dose vaccine. Public Health England, vaccine efficacy 73 to 89%, 75% reduction in asymptomatic infection, 45% reduction in household transmission. Here in America, Houston Methodist, our own employees, as you know, we have a almost 100% employee vaccination rate. Our positive test rate in our employees reduced by 95%. St. Jude Hospital, 94% reduction in asymptomatic, 100% in symptomatic after 2 doses in their employee population. The CDC, vaccination nationwide has so far reduced the incidence rate of all COVID infections by 90%. Here's some CDC data on breakthrough infections in vaccinated people, and I've compared it to the last year's data in people who were not vaccinated. Obviously, nobody was vaccinated before the end of last year, and I've rebased it to the same denominator. So breakthrough infections in the first 4 months of 2021, about 0.74 per thousand. 29% of those were asymptomatic, so less than 1 in 1,000. Last year, the COVID infection rate was at least, and probably 2 or 3 times higher than this, but at least 92 per thousand. So 90 per thousand, less than 1 per thousand. So this is basically a factor of 100. Hospitalizations. Before vaccination, 900 per million, probably way higher than this. After vaccination, 5 per million. Death, the ultimate hard endpoint. Before vaccination, 1,680 per million. After vaccination, less than 1 per million. I mean, if anything is going to convince you of the efficacy of COVID vaccines, this is it. Now, most of these are 2-dose vaccines, except for the J&J vaccine. The other 2 we have available to us require 2 doses. And I'm starting to hear, a lot of people say, hey, I got 1 dose, that's got to be good enough. I felt lousy. I really don't want to do it again. I'm busy, or whatever. So here's our data from 91,000 patients who have Methodist doctors and were vaccinated at Methodist. So we know the follow-up on these folks really well. If you got 1 dose, and this is the Pfizer vaccine, which is pretty much all we're using. If you got 1 dose, your prevention of hospitalization was 77% effective. If you got 2 doses, 96%. Prevention of death, 1 dose, 64%. 2 doses, 99%. Again, if this doesn't convince you that you ought to go ahead and get that 2nd dose, I don't know what would. Now, the recommended interval between the doses, 3 weeks for Pfizer, 4 weeks for Moderna. The CDC says up to 6 weeks is fine. I think it's quite possible that a longer interval will still be fine, but we really don't know. So we don't know the maximum interval. So, if you missed your 3 or 4 week appointment, try to get in there by 6 weeks, but get it. I'm really not going to talk a lot about safety today. It's a topic that's on a lot of people's minds. In a way, I think we've almost been focusing on it too much, because we're spending, I'm spending, half my talk talking about these 1 in a million or 1 in 200,000 events. And we totally blow past the idea that, you've got a almost nowadays 1 in 500 chance of dying from COVID. So this is really the only safety slide I'm going to show, just to remind us that in the clinical trials where people were monitored extremely carefully, more than 50,000 people got the vaccine. There was really nothing seen in the vaccine group beyond what was seen in the general population. And we now have 6 months of safety follow-up on these folks. And as you know, the severe effects of vaccines typically are seen within 6 to 8 weeks. Now, that's thousands of people. If you're going to get something that happens one time in a million, you could easily miss it when you're just looking at thousands of people. And indeed, we have seen, a number of things crop up in the real world experience now that here in America, we've vaccinated over 150 million people. Worldwide, it's got to be, a multiple of that. One of the first things we saw, and we saw this in, I think, probably about our 10th person that we vaccinated, is these severe allergic reactions, which I have the impression are more common with the Moderna and the Pfizer vaccines. Scary, uncomfortable, attention-getting, but very treatable. We have not had anybody pass away from this, unlike COVID, where we've had many people pass away. We have the right ways to treat this. We keep you around. We watch you for an appropriate length of time. And this is really, it's about 2 in a million. A lot of other stuff crops up. People who, the pain in the arm lasts for a couple of weeks. I have the impression this is more common with Moderna. Systemic rashes, which have got to be really scary, but they go away. One of the things we're asked about today, and I'm sorry that, we're not able to give individualized health recommendations. It would not be prudent or ethical for us to do that. But people having, inner ear things, tinnitus, for example, is something that a lot of people talk about on the web. I myself, I get vertigo periodically, and after my first dose of Pfizer vaccine, a couple days later, I got really bad vertigo. And I was like, geez, I'm not looking forward to that second dose, because as anybody who gets it, vertigo is really unpleasant. But I thought, well, a couple days of vertigo, death, I think I'll go for the second shot. I had no problems. So it's unclear. It probably is some kind of inflammatory reaction. It probably is related to the vaccine. A lot of times you'll see people get inner ear stuff after the flu or other viral infections. So that's just my guess. The most serious thing I think that we've discovered is this rare but pretty dramatic blood clot risk with the J&J vaccine. It is quite rare, but we have seen some deaths with this. Now, recently, the Pfizer vaccine was approved for emergency use authorization by the FDA in adolescents, and certainly, I think if you're child is going to camp or some other kind of summer activity, I would strongly recommend this. So let me just say a few more words about the J&J vaccine, and I'll give you my personal recommendation. This is not an official Methodist position. It's certainly not the official CDC position. This is just me, and so take it for what it's worth. But if you look at what happens in women over 50 per million vaccinations, we save close to 5,000 hospital admissions. We save over 1,000 ICU admissions. We save more than 500 deaths at the cost of probably 2 cases of this blood clot syndrome. Risk-benefit very strongly in favor. Women in the 18 to 49 age group, we save 600 hospitalizations, over 100 ICU admissions. We prevent 12 deaths at the cost of 13 cases of this syndrome. Now, if this were the only vaccine available to us, I would say absolutely, get out there and get it. But we have 2 other vaccines that are not associated with this phenomenon. So my personal recommendation is if you're a woman 18 to 49, get vaccinated with Pfizer or Moderna. Anybody else, you can choose any one of those 3, I think, very safely. The other question that comes up is EUA versus FDA approval. The FDA approved these vaccines for emergency use because we're having a pandemic health crisis where hundreds of thousands of people are dying. They carefully reviewed the scientific evidence. They thought it was compelling to approve this vaccine. What we've seen is that the real-world evidence totally backs that up. And in fact, Pfizer is going to be submitting for full approval soon, and I absolutely can see no reason why the FDA will not grant approval to them this year. So anybody who's waiting for FDA approval is going to run out of excuses. Update on the viral variants. Big issue, a lot of concerns. I can tell you that the D614G variant, which is what we had, most of the fall, pretty much all the vaccines took care of it really well. And in fact, this is a variant that came out of nowhere, took over Houston last summer, and everybody was, really very scared about it, but it has not been a big deal. Our current variant, which has superseded that one, is the B117 variant, also known as the UK variant. And here it's about 90+% of the isolates in Houston in the most recent crop of genome sequencing that Dr. Musser's department has done. And again, the news on the vaccine front is quite good here. Nothing to worry about. Now, there are, literally viral variants coming out of our ears all over the world, and it's really hard to keep track of them. The one that is probably of the greatest concern at the moment is this B1351 South African variant. It does appear to really have escaped the AstraZeneca vaccine. 76% effective against B117, 10% against B1351. It's in the yellow light zone for the J&J vaccine. Pfizer appears to be in pretty good shape against this variant. We don't really have good data on Moderna, but I would expect it to closely follow the Pfizer results. So, again, nothing to worry about. We had a question about the India variant. Not a lot known about it, but again, it's probably not escaping the vaccines. Probably more transmissible, maybe a bit more severe, not escaping the current vaccines. Pfizer data from the country of Qatar. Half their cases are B117, half of them are B1351. Prevention of infection, about 75% with the Pfizer vaccine for the B1351. Prevention of severe, critical, or fatal disease, essentially 100%. Similar results from the country of Israel for B117. So the question of boosters comes up. Moderna recently announced and pre-printed a study on their shots. They compared a third shot of their base vaccine that a lot of us have had, a booster tailored to this 351 variant, and also a 50-50 mixture of the two. What they found was that after 6 to 8 months after you got vaccinated, you had antibodies still detectable against the baseline variant D614G, but only 50% of folks had titers against the Brazil or South Africa variant. After the booster, you can see these are the levels of antibodies for D614, the South African and the Brazil variant, before the booster, after the booster. And the difference in the bars may not look impressive, but these are logarithmic plots. So a change of 1 unit is a change of 10-fold. And so you see basically a 10-fold increase in the antibodies after the booster. My guess, we're all going to get boosters every year, at least for the next several years. So the future, I think if we keep getting vaccinated, we give Dr. Boom his 45-day respite before we go out and start getting crazy. We are going to have something close to herd immunity this year, this summer, I believe. That means normal life with some additional precautions. I still wear a mask at the gym. I'll probably wear a mask at the gym for the next several months, probably put it back on at flu season. COVID is not going away. It's too far out of the box for that, but it's going to become a normal disease. Bad to have one more normal disease around the world, but a lot better than we have now. I do think at some point we're going to need updated vaccines, but the good news is these new vaccine technologies can be updated really fast. And someday in the far future, I think COVID is just going to be another cause of the common cold. But we got to get to the future first, and that's going to depend on a lot of vaccines, a lot of medical technology, and a lot of social cohesion, where we do stuff not only for ourselves, but also for those around us. So thank you.
Thank you, Dirk. Obviously some very encouraging news there. And again, that mantra of we all need to get vaccinated and protect each other as well as ourselves. I think that real world evidence is so compelling. It's one thing to see a study now, it's another thing to see a whole nation or a whole institution or others. I just want to put a finer point on the numbers you did for us. We had 225 people in that study period pass away from COVID, 225. Of those 225, 1 was vaccinated. 219 were unvaccinated altogether, and 5 were kind of in that 3-week partial vaccinated period. So, again, kind of to your point, I don't know how you get stronger numbers than that. It's just so patently really obvious what needs to be done.
Yeah, if you want to, not needlessly risk death, go get vaccinated.
Yeah, and you showed 64% protection with 1 dose. It's a big difference from 99% protection.
Yeah, it
and
really is.
In our own numbers, we've seen about 95% of people are coming back for their second dose, but we still got 5% kind of leakage out that we are working hard to track down so we can fully protect those individuals. And if you've gone to the point of getting 1 dose, by all means, go get the second dose is one of your key messages, I think.
Yeah.
Well, thank you, Dirk. Well, I'm going to give you an update really around the status of where things stand right now with COVID, but particularly our vaccination efforts as well. I've talked about this before over the last couple of times that we've been entering sort of a rough, steady state. This is our testing data. So in the blue bars, you see the number of people testing positive for COVID. You see for quite some time there at the bottom a pretty steady number. Now, the number of tests in the community has plummeted. But of course, if you're sick enough to come to one of our institutions, you're seeing those bars, and that's maintaining pretty steady. And in fact, the percentage, which is the orange line, is staying pretty stable. What we're seeing nationally now is the cases after a plateau period really are beginning to go down. And this is largely the vaccination effort, coupled with, of course, now getting into warmer times, people moving outdoors in some of the colder climates. But we're seeing, obviously, very encouraging trends overall. What we see at Houston Methodist from an inpatient perspective is we're trickling down. So, around about April 1st or so, we finished kind of the more rapid decrease. And you've seen kind of a steady state to a small trickle down. We're still well above the levels we were at in November, but we don't see these crazy spikes. And again, if I look week over week, we still see this trickling down. So I think that's obviously very positive information. Dr. Sostman already stole my punchline, but my key message is, you've seen these the last few times, trust the vaccines. And I've said that before, that works on two levels. Obviously, trust them in terms of their safety and their efficacy. Trust them in terms of your life. You are able to start doing things that you couldn't do before once you are vaccinated, once you're with a group of people who are vaccinated. And if we all do that together, just think how normal our world can become. But as I've said since the beginning of March, I was saying, give us 90 to 120 days then, sometime kind of in the month of June, you'll see, unfortunately, the pace of vaccinations really slowing down. So I'm not giving the window anymore. We need till the end of June to really make sure that the people who want a vaccine, who've maybe been a little reluctant, who've maybe had access issues, et cetera, that the medical community works together to get them vaccinated. But I do think if we can push that final bit, we can have a very, very normal summer. And of course, things have normalized dramatically compared to where they were before, particularly in our community compared to some parts of the country. Even the CDC, which has tended to be more conservative, is starting to move it, which I think they need to be, but which is moving some of its recommendations, has published data and projections now that in effect show, by midsummer, we have, very, very low levels of COVID. Now, I think most of us would expect we'll see some uptick again when colder weather hits in the cold and flu season. As Dr. Sostman talked about, there'll be some seasonality. There's always the risk of a variant that escapes. As you see, there are some concerns out there about that. We've honestly been rooting for if we had to have a variant, when we saw all of these show up at the same time in January in our first data, we were rooting for the UK variant because we knew it was the most susceptible, and indeed it has won out, at least so far, and we will have to continue to watch that closely. But all we have to do is watch stories of what's happening in a country like India, what may happen in other parts of the world, to see how bad this can get again with a bad variant, how much being unvaccinated as a population can really increase the risk. And so, again, the big message here is going to be pushing the vaccines. And here's the problem, right? This is all for one for all, nope for the other third of the population, which is, kind of right about the population that we're dealing with right now in terms of I'm either hesitant or I'm going to wait a little while or I'm in the hell no category, is probably collectively about a third of our population. And unless we work together as a community, we will not get to those levels we want to get to. So this is one of those times where every one of us in any sort of influence position, whether that's just a family, whether that's a group of friends, whether that's many of you who lead institutions, who are active in your church or your faith institution, et cetera, et cetera, et cetera. We need to make the norm be that everybody gets vaccinated, and then have the benefits be that we can then loosen up some of the things we do together, look each other in the eye and say, okay, we're all vaccinated, take off your masks, we'll be in a room together and have dine together, whatever those different things are we do. And so we can all impact that if we can change the dialogue and we can keep influencing the people we love and the people around us that we work with and know. This is actually the data around the country, and it's the percentage who say they want to get vaccinated. Darker color means more people. It's by county, although there's a couple states, as you can see, missing. But by and large, what you see is incredible variability across the United States. It trends along some political lines, as you see with that. It trends along urban versus rural lines and others as well. And we need to really urge everybody to put politics aside, as we've urged every step of the way with this, and just focus on the science, on the medicine, and get vaccinated. The good news is we do continue to see improvements in what people are saying they're willing to do. I've shown you these data before. The most recent now is March. The last time the most recent we had was February. And you see between the people now, about 20% on there, during that March timeframe who'd already been vaccinated, another almost 40% saying, yep, as quickly as I can. That's 60%. That's close to that 2/3 I talked about. In the light blue, you see the kind of, I'll wait a little while group, but we'll probably get them vaccinated. We've got to urge them to move more quickly. Let's get it to those individuals. And then most importantly, that group in the orange who are saying, I'm still uncertain whether I want to be vaccinated. Through every possible method, we need to be urging that group to get into the vaccinated category. Because this is what's happening nationally now with a, really remarkable, prodigious effort, peaking at about 3 million vaccines a day. We've come down by 50%. Now, it's tiny bit up there, and that's pre-Pfizer, authorization for the younger kids. So we'll see where that goes. But I'll show you some further data. It's actually worse than this looks, though, because this is, doses administered per day, and there's a 3-week lag between your first doses and your second doses. So what this means is the first doses are falling off pretty precipitously here. One of the reasons it's holding up still is because we're still getting people with second doses, and I'll show you some of our data around that as well. This is the vaccine allocations for first doses for Greater Houston. Now, this is the last week I will be able to show you this graph because the state shifted its structure, and now none of us are getting allocated vaccine. It's literally order what you need. But what you see already this last week, and this is what led them to that decision, it had absolutely plummeted because everybody was starting to build up some supplies. In fact, in the darker blue part there at the top, that's the Texas Medical Center institutions. We represent about 70-75% of that because we took our normal allocation, watching the kids come up and the fact that we've continued moving along. So again, we are really starting to hit the wall, yet we're far too soon to be hitting the wall. This is actually the doses administered, first and second, every week for collectively all of the Texas Medical Center institutions. And so you see that has been steadily coming down off of a peak, and it's in the 70,000+ range over that last week, first and second doses cumulative. You saw the supply was less than that, so people are working out some supply. And again, that supply is first dose only. This is first and second doses. This is our experience at Houston Methodist. So you see we've curtailed less than other institutions. In fact, we brought it back up last week. You can see 40,000+ doses. Keep in mind that last one showed 72,000 or so across the entire TMC. So we are really, fighting in a higher weight class, so to speak. I mean, we've been pushing this, and I think it's all the strategies that we have used to continue making sure we're getting to the community. But collectively, these are markedly lower numbers. And what this hides is that thing I referenced, which is the second dose, and you see that here. This is every day the doses given at Houston Methodist. In the blue are first doses, and in the orange are second doses. So part of the reason we're continuing as high as we are, and you would see this with everybody, is that we're getting that 3-week out, still when things were going pretty fast for the first doses. We're now seeing, whereas we can, with our regular allocation could get 24,500 doses for a first dose, and we were using those every week. Now we're seeing it's only coming in about 9,000-10,000 people in a week that are getting first doses. Now we're going to see a little pop, I think, here because of the 12 to 15-year-old Pfizer, but I don't know how long that pop will happen. And when we do surveys out there, somewhere around half of parents are saying, yes, I'm going to rush and get my kids vaccinated. Every one of them should be getting their kids vaccinated. You know, you heard these effects. We don't understand at any age group what the 5-year, 10-year, 15-year, 20-year effects are going to be of having had this infection. And we want to prevent those going forward. We are now at 718,000 doses overall, which is, you know, a phenomenal number. I had once upon a time hoped we might get close to 1 million. Clearly, that's not going to happen. We'll probably settle out in the 800 to 900,000 range is my guess. This represents 383,000 individuals in the greater Houston area who've received vaccination from Houston Methodist. And as I mentioned before, we have about a 95% second show rate, which is about 2-3% more than we're seeing reported nationally, but it's 5% too low. And so we're doing everything we can to bring those individuals back in. We know who they are, we can contact them, etc. And we will do everything we can to help keep bringing them in. As I mentioned, and Dirk mentioned, 12 to 15-year-olds are now fully cleared. We are now scheduling and walking in patients in that age group, and we'll do everything we can in that age group. We're hoping the next levels down, and actually Pfizer is signaling that it won't just be the 5 to 11, it may be the 2 to 5 and the 5 to 11 groups that they're studying by about the September timeframe, which of course would be great in terms of getting our kids back to school and having school be as safe as it possibly can. So we have walk-ins. We have Monday through Friday, typically 8 to 5. Tuesday, Thursday now extended hours to 7 p.m., including tonight. If you want to get a dose for your child today, walk on up to one of our 7 sites or go online and schedule an appointment for later today. You'll have a smooth, effective, easy experience, and you'll know that you've taken the first step in protecting your child, your family, your loved ones, your community. And so please, by all means, do that. We continue to push, and Dr. Sostman talked about it, you can get this on our website, pushing out counter information to all of the vaccine myths that are out there. Much of it, is sort of breathless reporting of things at times, and much of it is very cynical, purposeful misinformation by people who don't like vaccines in general and who see COVID as their opportunity to have a platform to really fight against vaccinations in general. We've been getting as creative as we can. I mentioned the baseball with the Astros, worked pretty well. I would have loved it to be a lot more than 100 people, but we are very rapidly shifting into that philosophy of we'll do whatever it takes, person by person by person, because every time we do that, we protect them, we protect the community, we protect people around them. And so we're shifting, from what was this very high throughput strategy into a very high touch, high labor intensive process. And we will be there till the end of this process to get that. And of course, we'll be there at such a time as we need to do boosters, et cetera, in the future. We've gotten very creative with a number of other things. One of the local rap musicians who helped us with an event that we did also with the Houston Music Foundation and the Heights Theater, really trying to do everything we can, and I really commend him for stepping up and using that as a platform and using, frankly, his notoriety and his celebrity to encourage others in our community to follow suit. And we want to see more leaders in the community continue to do that. And of course, at Houston Methodist, we are the first hospital system, and now still one of only 2 that I know of in the United States, although from the conversations I'm having, there's going to be many, and it's going to be mostly everybody eventually following suit. And I think there's a number that are relatively close from talking to them around the country. And this has been highly effective. What you see right now is that on March 31st, when we made the formal first announcement that we were moving this direction and mandating for our management, and then on April 16th, when we made the announcement for the rest of the institution with a June 7th deadline, we moved from about 84.5% of people who were received their vaccine and were compliant with our what ultimately would be our mandate, and we are at 97%, 96.95%, and obviously we have several weeks to go before that. So we're already the safest hospital anywhere on the planet as a result of this around COVID, and that is always our goal. It's been one of our guiding issues from day one. always, but certainly within COVID. Very proud of this. We continue to get a lot of attention, a lot of press, most of it positive, some of it because of all the nasty anti-vaccine stuff out of it, some of it a little nasty, and that's okay. That's what it takes to lead. That is leading medicine. That is putting patients at the center of everything we do. And many of you know a hospital structure. The way it is structured in the United States is each of our medical staffs are independent entities. They report up to our boards of directors, but they are independent unless, of course, you're an employed physician. So most of our physicians are not employees across our institution. We have about 900 plus employed physicians. They get treated from a mandate perspective in the same way, but the other 6,000 individuals or so are on each of these medical staffs. Every single one of our 8 medical staffs has mandated the vaccine on the same time frame as we have done for an institution. Again, kudos to each of them. Kudos to our medical staff leaders. We are, and we will continue to be the safest place on the planet. I am absolutely proud of our team for everything they have done through this. It'll make for a little bit more noise again over the next few weeks, but the bottom line is we will get almost everybody across the finish line. We're doing that as compassionately and with town halls and with as much personal attention as we can for each individual who sort of needs to move through that thought process of how do I put patients first, protect patients, get vaccinated, comply with this policy and move forward. And so I'm very, very proud of our team for what we've already accomplished, and we're almost there. We're going to keep on moving that number up. So again, trust those vaccines. Give us this 45 days, and I think we can really loosen things up. Now, you can already have been sort of, ratcheting back, as I've alluded to, but in those large public environments, in the supermarket and many other places you go, in the gym, I think there's a lot of protection that still needs to be there, if nothing else, but for the courtesy of others who haven't yet been vaccinated, haven't had the chance to be vaccinated, might be in the process of being vaccinated, etc. I want to finish with this lovely image. This is actually from a street artist named Banksy. Many of you have kind of heard the stories about Banksy in the UK. Banksy is an unknown, actually. I mean, I think people think they know who it is, but he's technically assumed a he from who they think it is, unknown. But he's a street artist, and he actually created this beautiful image of a child sort of throwing away his Spider-Man and Batman superheroes and having the superhero of, the old-fashioned kind of nurse garb there, and the only color in the picture being the red cross there. Just a beautiful image. This was actually painted or drawn and put at University Hospital in Southampton, and then they turned around and said, let's put a replica there and let's auction this. It sold for $23.1 million with the funds donated back to that hospital in support of hospital heroes. And boy, I can't think of a better image to really talk about all the heroic people working in hospitals and in healthcare throughout this, and enjoy this image. And thank you all, as always, for your support. Now, I alluded to this before. I actually, because of the vaccine mandate, we're getting a lot of press attention around the country, which I'm thrilled with, because quite frankly, we're leading the way. It's showing the way for other institutions, hospital systems, and others to move forward and mandate, as they should honestly have already done in all of those cases. And so I've got one of those live appearances in a few minutes here. So I'm going to sneak out and I'm going to turn things over to Dr. Sostman, who is going to facilitate the question and answer and be able to stay here with each of you as long as he needs to. I do want to cover one question I see popped up on the chat, which is, okay, somebody with no insurance, no social security number, can they get vaccinated? If you are a human being and you show up at one of our sites, you will be vaccinated. This is a human question, so don't worry about any of those issues. There's no cost to anyone. Obviously there is a registry that happens, but that registry is for the sole purpose of making sure we're taking care of people, and of course making sure we look at the safety and other concerns and understand the person we are vaccinating, and that's the sole purpose. So by all means, everyone should come in and get vaccinated, no matter what. Thank you, and God bless.
Great, thank you, Mark. It's been a really interesting session so far, and the time for us to attend to some of the questions. I'll take the first one, which is, do the COVID vaccines affect menstrual cycles in some women? And yes, sure they do. This is, I think, as everybody who has personal experience with this knows, pretty common with, influenza, and it's really based on the mild inflammatory process that the vaccine induces while it's training your immune system. So yes, it can happen. No, it's not something to be concerned about. And 100 times no, it does not mean anything about your fertility. Question for, let's see, let me take one for Dr. Roy while Dr. Kurrelmeyer is getting in her seat. When you have leg pain, what are some symptoms that you should watch for and which ought to prompt you to go to the hospital?
So I think that this is a really important question because, like I said, there's been a lot of delays and fear and anxiety about going to the hospital. You should feel safe to come to the hospital, but for sure, if you're having pain at rest, if you are getting woken up at night because of your leg pain, if you have any sort of open wounds that are not healing, these are really important signs that your legs aren't getting enough blood flow and you should come in.
Great, thank you. And for Dr. Kurrelmeyer, are we seeing advances made in using medicine more than surgery to treat heart problems in women?
I would say yes, absolutely. If we're talking about coronary artery disease, which was the very first part of my COVID talk, we detect, now that we have coronary calcification scores or heart scans, we can detect early heart disease, early evidence of heart disease, or what we call evidence of plaque formation, which precedes those blockages that I talked about. And so when we see those, we can put women on a bunch of medications, specifically statins and aspirin, and control all the risk factors, and that will absolutely prevent them from needing to progress to needing bypass surgery or stents. So yes, I would say overwhelmingly yes with respect to coronary artery disease. With valvular heart disease, what you see is we have more percutaneous therapies now. We have valves that we can put in the cath lab. So even in that field, surgery is less and less likely to treat the valve problem that women have, because we can more often treat that in the cath lab with these percutaneous stents.
Great. Yeah, it's really amazing how these advances have revolutionized cardiology and made the outlook for heart disease so much better than it was when I was training.
Absolutely.
And since Dr. Boom is not here in the studio anymore, I'll point out that was a long time ago. So, what other diseases can the messenger RNA vaccine technology be applied to, and what's going to be the next area of focus? Well, there are a lot of other infectious diseases that have been looked at with mRNA vaccines. And probably the next big target is going to be influenza, actually, which is a virus that changes radically from year to year. The vaccines that we produce each year are kind of based on educated guesswork. And that's why some years they're pretty effective and other years they're not very effective at all. The mRNA vaccine is much more timely and probably will greatly enhance our ability to control influenza. The other big area that a lot of companies and academic researchers are working on is cancer vaccines. And these are not vaccines to prevent cancer. They're vaccines to basically train your immune system to attack and kill a cancer that you already have. A lot of work being done on this, and some, I think, pretty exciting things are going to happen over the next 10 to 20 years. So we did the leg pain question. A bunch of questions came up about travel. can we take our baby traveling this summer? Can we travel internationally? Is it safe to go to Europe if we're fully vaccinated? And then the last question on, what are the European health passports going to look like, and will our medical system be able to respond to this requirement? So for the last one, I think it's uncertain at the moment. And anybody who's dealt with the EU knows that they have layers of bureaucracy that we in America have not even dreamed of. So what their health passport is going to look like, what the requirements are going to be, it's unclear. One thing that I know they are talking about is that they would only be valid for somebody who's been vaccinated within the last 6 months. So you might actually have to get vaccinated again if you got vaccinated really early and you're desperate to go to Europe, under this health passport system. But the answer is we really don't know what their requirements are going to be. As far as travel in general, I think it's a judgment call. The further you're going, the more dangerous or the more prevalent COVID is in the place that you're going to, I would say the less safe it would be. It's really hard to give a general answer to this. I think, read up on the place you're going, exercise common sense. Even if you're vaccinated, I would definitely mask up and do all those precautions. Airplanes are probably fairly safe. It's actually the standing in line at the airport that's more dangerous. I would tend to do local trips, places that you could drive in a day until probably next year. But it's up to you. And if you have a compelling reason to go to Europe for family or something like that, if you're fully vaccinated, I think you can do it safely. I would lay in a supply of N95 masks. I would bring lots of sanitizer. I would bring lots of wipes to wipe down, particularly the tray table on the plane. The longer the trips are, the harder it is to stay safe. So short flights, probably quite doable, quite safe. So how can you determine when your kidneys aren't functioning properly? And one of the reasons we know that you can have kidney failure is our old friend COVID. I don't like to sound like a broken record here, but this is a really bad disease, if you hadn't gotten that message already. But especially if you've had kidney failure previously, and I'll throw that one to Dr. Kurrelmeyer.
Sure, thank you. So, I'm not a nephrologist, I'm a cardiologist, but COVID can affect the kidneys very similar to the way that we were discussing how it affects the heart. So absolutely, it's not just isolated to the heart and lungs, it can affect all the organs. So for this one though, this is actually a pretty easy answer. Usually what we want to do is we follow the blood tests. So we have specific blood tests called the BUN and the creatinine and the estimated glomerular filtration rate, or EGFR, that comes on daily blood work when patients are hospitalized, not for COVID, but for almost any reason. So we're literally following the kidney, how the kidneys are doing when you're in the hospital every single day. Of course, we can also check a urine sample, because that also tells us a lot about what's going on with the kidney. And we can also, spot check it or check it for 24 hours, because that's a more exact way to see how well it's working. But again, we have multiple different, between blood tests and urine tests, of determining how well the kidney's functioning.
Great. Immunocompromised patients receiving immunosuppressive treatments. The example given here was Ocrevus for multiple sclerosis. Or patients who are getting immunosuppressive treatment for solid organ transplant. What's the situation and what's the future hold? Well, unfortunately, a lot of people who are immunocompromised by reason of their disease or the treatment that they're getting are not responding well to vaccines. So certainly if there is any way that your treatment can be altered to give you a window in which you can be vaccinated, that would be great. For example, here at Methodist, we're trying very hard to vaccinate organ transplant recipients before the transplantation is done. Ocrevus is an example of an anti-B cell therapy. It's B cells are the cells that produce antibodies, so yeah, it's not at all surprising that you're not showing antibodies. What can be done about this other than trying to vaccinate before treatment or in a treatment window of some kind? There's not a lot of good answers at the moment. One thing that we're going to be trying here at Methodist is when the Novavax vaccine comes in, which uses a different mechanism of prompting your immune system. We're probably going to be trying to vaccinate again the patients who have not responded with good antibody response. The one thing you can do is remember that if you're in a high-risk group, and if you're immunocompromised, you are, if you get COVID-like symptoms, get a COVID test, because we can give you monoclonal antibodies that will protect you very, very greatly. And if you have a patient advocacy group, get your patient advocacy group to contact the FDA and ask them to add to the emergency use authorization for monoclonal antibodies prophylactic preventative use in people with immunocompromise, because the data is very, very good that monoclonal antibodies given prophylactically will protect you very, very well from COVID. So this is something that if you have a patient advocacy group, they can do to help. But certainly if you think you're getting sick, make a beeline to your doctor's office, get tested, and we can really help you with monoclonal antibody infusions. Likewise, a safety question on pregnancy, and we don't really have great data on vaccine safety for pregnant women. The companies, the FDA, all of us, for very good reasons, put pregnant individuals in special category of needing to be kept safe. And so they are not the first group that gets incorporated in a clinical trial. The data that we have from people who have been pregnant during clinical trials or have elected to get vaccinated while pregnant is very reassuring. There have been no unusual events that would say that this vaccine is a high risk. As you know, OBGYNs typically recommend that their patients who are going to become pregnant top up all their vaccines, make sure their vaccinations are in order. And the reason is that phases of pregnancy involve, phases of transient immune suppression, and you can get sick when you're pregnant. COVID is a great example of this, particularly in the third trimester or the perinatal period. You are at higher risk for getting COVID, and you are at higher risk for complications. Toxemia of pregnancy, preterm birth, fetal distress, and maternal death. The death rate of new mothers from COVID is about 22 times the death rate of the population of new mothers who have not gotten COVID. So again, risk-benefit favors the vaccine. Restaurants and indoor indoor social events, same deal as with travel. Use your judgment. I personally have not eaten inside a restaurant since January of 2020, but lately I've been going to a lot of outdoor dining, and thankfully here in Houston we've got 1,000 really good options for outdoor dining. So my point of view on this would be it's probably relatively safe. It'll be a lot safer a month from now, and it'll be a lot safer a month after that. What's the rush? The India double variant, I think I covered this in the presentation. It's probably more transmissible. It's probably associated with more severe disease. It's probably not escaping from the vaccines. And then the 95-year-old father to see family members who are not vaccinated, including a 39-year-old grandson and a 5-year-old grandson. First of all, I'd like to compliment the dad on having a 39-year-old and a 5-year-old grandson. This is obviously a tough guy who's more than capable of fighting off COVID. But again, use your common sense. I think it's perfectly safe for dad to see those family members outdoors. If it's got to be indoors, could it be, for a few minutes at a time? Don't hang out in a small room without masks and coughing dad's face, basically. Use your common sense. I had my second vaccine 3 months ago. Given the reluctance of so many who don't want it, if there is a surplus, can I get another vaccine? Yes, you can. We don't, at the moment, know of any reason why you ought to. But basically, here in Houston, you can walk up to any number of places and get a vaccine. So if you want to get vaccinated again, it's certainly possible. Few questions have come in. What's the percentage of people with severe negative reactions to vaccines? We don't really know, but certainly less than 1 in 100,000. If you add up all of the potential negative effects, and this is really very safe. You're much more likely to get permanently disabled or killed driving to work each morning. What's the infection rate you're seeing for adults who've received both doses of the vaccine? Well, very low. I mean, about 1 in 1,000. How sure can we be that our personal information in the vaccine registry won't be victim of a ransomware attack? In general, here in the United States in the 21st century, as far as your safety of your personal information, you're hosed. Your personal information is already out there on the dark web, and the only thing that's keeping you safe is the fact that there are not enough criminals out there to use all of the personal information that's already been compromised. Why is the antibody test not automatically added to routine blood work? Well, this actually, there's a couple of reasons. One is just because we're trying to hold down the cost of health care. And the more, tests we do that we don't know what to do with, the more, healthcare inflation will happen. The second thing is that in the majority of cases, we don't know what to do with that information. Although a lot of people are working on so-called correlates of protection, We don't really know what they are now. It probably is going to be the level of neutralizing antibodies in your blood is probably going to be the major correlate of protection. But we're sort of in the position of, the guy who's looking for his car keys under the lamppost because that's where the light is best. It's pretty easy to measure antibodies. It's pretty easy to measure neutralizing antibodies. It's harder to measure cytotoxic antibodies. It's harder to measure cell-mediated immunity. So we're measuring what we can measure, and actually the data there is looking pretty encouraging that at some point we'll be able to tell whether you're protected by doing a panel of neutralizing antibodies against the variants. But we're not there yet. So, a number of us on the medical staff have gotten our antibodies measured just out of personal curiosity and, the kindness of the laboratory. And you get the number and you go, great, what does that mean? Who knows? It's not ready for prime time. Will the current vaccine soon be obsolete with all the variants? So far, so good. In fact, the Pfizer company is thinking that their booster may well be the same vaccine they've already developed just to boost your antibodies. Because the secret here is that these variants, at least every change in the variant makes it a little less recognizable to the antibodies. It's like if I grew a mustache, you'd still recognize me. If I put on a wig, you might not. but the vaccines recognize the virus, just not quite as well. So you can either tailor a new vaccine that recognizes it better, or you can just boost the level of the antibodies in your blood. At least with the current vaccines, that tends to have the same effect. So probably someday the current vaccines will need to be updated. Good news there is that the mRNA vaccines are really easy to update, and we should be able to keep ahead of these viral variants pretty expeditiously. So I think we've run out of questions. I really want to thank Dr. Roy and Dr. Kurrelmeyer for stepping out of clinic and giving their time to tell us about some of these effects on cardiovascular fitness and disease and help answer some of the questions. And I hope you've enjoyed and found interesting this session, and we'll be back next month. So until then, stay safe. Remember, you can get your COVID vaccine at any of our hospitals without an appointment, including those 12 to 15-year-old kids. Next month, we will be actually focusing on men's health. Dr. Brian Miles will be here, and it's also National Cancer Survivors Month. So Dr. Polly Niravath, who heads our Cancer Survivorship Clinic, will be here. I think it's going to be a really interesting session, and if you'd like more information about the women's health issues we discussed today, or the Society for Leading Medicine, which kindly sponsors these sessions, please contact us at the email address that we're going to shortly project on the screen. So God bless, stay safe, and we'll see you again soon. Thank you.